Welcome to the Happy Doc, the voice of fulfilled physicians. This show is about bringing inspirational, creative, successful, and happy health professionals to you. Get ready to learn how you can be a happy doctor too. Hello, everyone. For this episode, we have brought on the Grim Reaper. I'm just kidding, or we could say he's an angel. I don't know which way to look at it. Dr. David Buxton is a palliative care specialist. And, a lot of people look at palliative care as the people who deal with people who are dying. On other end of it, however, these are some of the most caring individuals in the hospital. They have to have really tough conversations, and they're like the angels. I don't know which way to look at it. Maybe you guys can let us know what you think. But Dr. David Buxton is a palliative care specialist. He started in the field of psychiatry. Then he went and did a year of fellowship in adult palliative care. And the reason I used adult is because he then transitioned to pediatric palliative care. And so he works with adults and children and has to deal with these very tough situations with families. Dr. David Buxton is the CEO for the Center for Palliative Psychiatry, and he works in Richmond, Virginia. He has writings which have been included in the Journal of Palliative Medicine, the Journal of American Academy of Child and Adolescent Psychiatry, the Psychiatric Annals, Neuropsychiatry, the American Medical Association Journal of Ethics, the Association of Community of Cancer Center, and KevinMD.com. He is a frequent speaker and thought leader on adult psychiatry and child psychiatry, palliative care, digital health care, social media, mental health innovation. And the biggest thing that Dr. Buxton foresees his career looking into is the focus on trying to figure out how social media affects healthcare and understanding the upsides and the downsides for the average patient. In this conversation, we learn about Dr. Buxton's practice in Buddhism, a study he learned in college, and which has had a huge impact in his practice as a physician. Just to give you a little bit of a flavor of Dr. David Buxton, here's an excerpt taken from his article, Redefining Medical Success, which was written in the Journal of Palliative Medicine. It says, "After a multitude of discussions with family and friends, I realized that each one of us has our own unique view of death, depending on our culture, religion, profession, etc. Death can be seen as a final moment of despair or a celebration of life, depending on the individual. This echoed Buddha's teachings that death is unavoidable, but an individual's perspectives determines the relationship to it. I believe my view of death has been distorted by my immense recent focus on healing and prevention. I had forgotten the reality that all humans will die. Remembering and further accepting the simplest of truths has made me feel more comfortable and thereby less fearful of not having all the answers to patients' questions when they are faced with death. It seems that in the end, each person's view of death dictates if they will live happily ever after. The ultimate wisdom is that no one will get out of here alive." And there you have it. That's a super powerful quote from his article. And guys, this is a really amazing conversation. We get into topics such as Dr. David's journey into medical school and residency, the experience he's had as a psych medical student and psychiatry resident, and the biases that students and doctors have on psychiatry students and residents. We talk about how David dealt with the tough times in residency, and I loved the game that he played with his co-intern or co-resident during that time. That's a great part of the conversation. How do we deal with burnout in medicine and getting through tough times, and much more. So, guys, please enjoy this conversation with Dr. David Buxton. Please check out his website, davidbuxtonmd.com, and you can reach him on his Twitter handle at davidbuxtonmd. That's David, D-A-V-I-D, Buxton, B-U-X-T-O-N, M-D. And yeah, guys, enjoy the conversation for today. So hello, everyone. This is Taylor Brana from the Happy Doc. I'm really excited to have our next guest. That's Dr. David Buxton. So he initially went into psychiatry. He then did a adult palliative care fellowship, and now he's moved on into the field of pediatric palliative care. And we'll dig into what that is, how he kind of built that career path for himself. So Dr. Buxton, can you introduce yourself?
Sure. Thank you so much for having me. Really happy to be here. Yes, I'm an adult psychiatrist, child psychiatrist, and also a palliative care physician. So kind of a unique combination of specialties.
Awesome. And so for the listeners here today, where are you located?
Sure. I'm located in Richmond, Virginia. I work at an HCA hospital, and I also keep a private clinic where I see kids and adults for both psychopharmacology and also therapy.
Awesome. Well, it's really great to have you. I'm very thankful for you being here today. And so we actually spoke prior. So we've had a sense of getting to know each other a little bit. This is the first episode in which I'm also interviewing a fellow psychiatrist. So it's really, I think it's very homey personally. I think we definitely, our specialty has a specific style of conversation. It's very refreshing in a lot of ways. So let's dig into some questions here. So I would love to just kind of understand how you got into medicine in the first place.
Sure, absolutely. And I think it's also quite an honor to be the first psychiatrist to put a little expectations on this. Well, hopefully the two of us can live up to this. So I got into medicine. My father's actually a psychiatrist, talking about psychiatrists, and my mom's a therapist. We live in a small town of Richmond, Virginia. So many of my mom's patients were seen by my father. So it's actually a story in the family that they would always present patients at dinner. So my sister and I never knew that was odd, but we'd always hear these stories about different patients and their families. And at times my mom wouldn't know who my father's seeing and vice versa. And so I think it just became the norm. When I was younger then, my dad said he knew I was going to be a psychiatrist because at some point he would ask me how soccer games were, and he'd want to know what the score was, and I would want to talk about why the coach was yelling at his wife and made us run extra laps. So he said he always knew I was going to be a psychiatrist.
So did you feel, I guess it kind of was ingrained in you a little bit. Did you feel like there was pressure from your family at all to go into that field, or was it, really your choice?
I think it was my choice on some conscious level, but on unconscious level, I think it was always kind of the driving force. Even I kind of joked around about dinner table, but I think when we would go out on vacations or for dinner, I think there was always this kind of discussion about why people were doing things and who people were. I think that's kind of how my family always oriented, like the human psychology of the experience. So I think maybe unconsciously it was always, I knew I was going to do this, but consciously my parents actually allowed me to kind of really explore different things.
Yeah. And the reason I ask is, just out of curiosity, you said psychiatrist and therapist in the family. And then it's like, oh, duh, like David's going to be the psychiatrist. It seems really obvious. But do you think that, another thing I always get curious about is, do you think they kind of cultivated that interest? Did they see a gift in you and help you out on that journey?
Such a great question. I thought the question you were going to ask me was, the last psychiatrist will be like, will my kids be weird? Like, that's always like usually the child psychiatry question. So, but I think they saw that I was interested in it and I had questions. And I think both of my parents are very curious. My father actually tells a story that he knew he was going to be a psychiatrist because in medical school, to make extra money, he drove taxis in New York City. And he became really fascinated by hearing these stories that people would tell him. So I think my father's orientation and also my mom's orientation, like they are the ones kind of explaining the world as a child psychiatrist. I always think parents explain the world. And so I think they always highlighted kind of the human struggle and how people engaged with the world outside. And so I think that was kind of always around me, both consciously and unconsciously. I was picking it up.
That's awesome. So to move forward a little bit, so you had this interest, you went through school. Did you know by the time you went to medical school that you already wanted to go into psychiatry, or what? Did you kind of keep that option open?
So I took a little bit of an odd path. I actually was a religion major. In middle school, I read the book Siddhartha by Hermann Hesse, and I got super interested in Buddhism. And so when I was looking at colleges, I wanted to go somewhere where I could learn about Tibetan Buddhism specifically. So I ended up at Emory University because they have an affiliation with the Tibetan monastery. Wow. And His Holiness, the Dalai Lama, was there in 97. I went in 99. So it was like this developing relationship. And during that time, I just the luck of being in the right place at the right time. One of my friends was a Tibetan monk who was sent to Emory to learn how to bring basic sciences back to the Tibetan monastery system. The Dalai Lama felt like they needed to have Western science in their curriculum as monks. So my friend actually was brought over to learn the sciences translated. And he was able to connect me in with the Dalai Lama's sister. And I ended up doing a research project in the Tibetan orphanages in India, which was so cool. It was an amazing experience. It's like, again, one of these things that like just right time, right place.
Wow.
And so I actually teamed up with Emory's Psychiatry department, which was a really strong department at the time. It was probably one of the strongest ones in the country. And the idea was to look at Tibetan adolescents and see if they had depression, anxiety, and PTSD the same way as we would expect in America, partially because they had fled China and there was all this trauma that occurred. And so I had this idea that if you're a Tibetan Buddhist, you kind of expect life to have some suffering. And so it wouldn't have the same impact. And I was wrong. They were very traumatized. I think they had a lot of struggles. And during that process, I became more and more interested kind of in psychiatric research and that experience.
So, when you were telling that story, my expectation also was, okay, so Tibetan Buddhists, I think that they expect suffering. They've been taught the practice of meditation, mindfulness, thoughts about, the ability to accept, right? All of those things that I would associate with that, group and religion. And it turned out, so were the groups similar or exactly the same, or?
It's actually interesting. Part of the thing is all the instruments we used, that you're familiar as a psychiatrist, were things that had to be translated into Tibetan. So it took us about 6 months to try to do cross translations of them. So one of the things was, how well do they translate? And then can you compare it in Tibetan versus English?
Right.
And I think the thing that was interesting too is a lot of the orphans I saw had to leave their families. And so there was this ongoing trauma that they were away from their families. They didn't know what happened to their families. And so it was kind of catching them in this kind of really difficult period of time, not like after the events, because the events were continuing.
Yeah.
And so after that project, I came back and had met with my mentor in the Emory Psychiatry department. He's like, you need to go into psychiatry. Because I had at that point been playing with doing a PhD in Tibetan Buddhism and religion. I'd been playing with becoming a psychologist, and he really pushed me pretty hard to go ahead and go to medical school.
Wow, that's a really interesting story, man. So I would love, we don't have to dig too deep into this, but I'd love to understand how you being exposed to, this religion and this group, having these experiences, what principles did you learn during that process? What did you take away from that experience, and how was it helpful for you as you went into medical school?
Sure. So I'll be totally transparent. I was not a great medical student. I struggled in medical school. I mean, it was really far from studying religion. And so I think what I took away is I really loved working with the orphans, doing the project. It kept me, actually, it was an energy to allow me to survive medical school, because medical school is really tough. It's I think it's my bias. I think psychiatrists, and you could probably talk about it, psychiatrists sometimes struggle in medical school because it's a unique field, unlike other parts of medicine.
Sure. Yeah, definitely. And yeah, we'll definitely, I want us to move towards that direction too.
Sure.
So, but do you feel like, before we move there, but do you feel like
Sure.
any of the things you learned from kind of the Buddhist religion, anything like that, do you think like you were able to apply some of that in school, what you were saying?
So I think so. I mean, I think one of the things is everything in life, I think, is relative. And you kind of keep yourself in check when you see people that had to leave their home, had to leave their families in this strange place. And so I think that part of it, I think from a Buddhism perspective, I think mindfulness has gotten really big in our culture.
Yeah, definitely.
I think for me growing up, that was not something that was really kind of an in thing. It's amazing how it's taken kind of this huge wave. But I think some practices, I think, definitely help. I think now with the death and dying population that I sometimes are working with and the chronically medically ill, I use those things much more often in terms of understanding that this is kind of life. Good things happen, bad things happen, and it's kind of the impermanence nature of it.
Sure. And I want us to talk about, how you deal with those situations, and we'll definitely get there. So yeah, I will talk about, the medical school experience. I feel like, and this is something I've learned, from talking to other, psychiatry students, for example, and people who are kind of interested in the more emotional, empathetic portions of medicine. I'll give you an example of this from my experience. I'm sure you'll have something similar. So I remember like when I was on surgery, I actually don't mind doing procedures, by the way. I think they're kind of fun. It's cool to say that I did, some of the surgeries I've seen, like the Whipples and, the lab choles and all this stuff. But I always thought, I would think afterwards, man, how does this person feel to be undergoing this procedure? Or how is this person going to feel after the procedure? I'd be thinking about, what their feelings and thoughts were going into that stuff. And I would want to be the one to explain the risks and the benefits. I was okay with that. The more humanistic portions of it, where I would assume that the surgeon, and I've seen it before, are they pooping? Are they passing gas? Let's get, and that's not to say that there's surgeons that aren't humanistic, but do you feel like that was kind of a similar experience for you?
Oh, absolutely. I mean, I think for me too, is I was known to be a psychiatrist, likely because I went to medical school in my hometown and my father's very well known here. So even if I wanted to hide that I wasn't going to be a psychiatrist, it was pretty blatantly clear I was going to be a psychiatrist. But I think it's difficult. I mean, I think one of the things is it was always really hard, almost like wearing a scarlet letter at some point when people would ask you during your third year, what are you going into?
Sure.
And you would say psychiatry. And depending on that individual's what I would call transference or countertransference to what psychiatry meant to them personally and professionally. The irony of it now is as an attending, I find that other specialties respect me so much more because if you're a surgeon and you have a borderline patient that's causing a lot of chaos for you in recovery, you're going to want the psychiatrist to help you out. So it's been a flip. And I wish someone had told me that in medical school that, hey, it can be a little bit rough at that point, but later on things catch up again.
Yeah, definitely. And I think, something that I've seen for better or for worse, and I've seen it actually play out in a couple of ways, is I've seen medical students say like, oh, I'm going to psychiatry, I won't need to know this stuff. Okay. So that's a negative thing, right? Because
absolutely.
Because there's a lot of medicine you should still know because you're dealing with people with lots of medical problems besides the psychiatric. And so I think if you play that card really early, you take that weight off of yourself and then you're not learning as much, right?
Absolutely.
Then I see it on the other end where the teacher's like, oh, they're going to psych. They don't, the attending or supervisor. How do you what do you think that comes from?
I mean, I think it comes back to, I was actually talking to someone about this today. A medical records company was contacting me about electronic medical records, and they were asking me if I think psychiatric medical records should be separate. And I think it's this all throughout medicine. It's this division between, for some reason, the brain, and the rest of the body. I mean, I always tell people Freud was actually a neurologist, right? We've theoretically broken the two apart. But I think even with the new stuff with the gut and brain connection, I mean, I think in the next 30 years, we're going to see they're much more connected. I think for some reason we have decided to disconnect them.
Yeah.
But I agree. I think as a palliative care physician now, I have to do a lot of medicine. And I think even if you're going to psychiatry, the more medicine you know, it's always going to be helpful.
Yeah. Yeah. And like we were talking about this today on my medicine rotation, like, you know, everyone, no matter what, you know, doctors should have a sense of how to manage blood pressure. They should have a sense
Absolutely.
of like how to manage diabetes. Because regardless of, you know, who you see, everyone has this stuff, right? So, yeah, I just think, you know, I'm sure there's some legal issues why you need to consult people and stuff. I'm not that far yet, but, you know, I haven't dealt with that part yet. But, you know, it's just interesting how, oh, you're in psych, you don't know anything. I'm like, dude, like, I learned all that stuff too, you know.
I might have gotten a better grade in like nephrology than you, right? Like that's the funny part. Like, especially early on.
It's just it's an interesting thing. But yeah, for all the listeners out there, there is that kind of stigma out there, and there's obviously a stigma with patients too, which is, I'll give you an example. Actually, today, had a patient having you know, some emotional stuff, and apparently a med student went in. He was working with the psych team, walked in to see this patient. And he's like, oh, you're from psychiatry. I don't want to talk to you. This is a guy having, you know, a tough problem with his family. Obviously, I'm not going to get into details about that. But just to say that, like, the psychiatry doctor's walking in. No, I don't want to speak to psychiatrists. So, you know, to people who might hold that stigma, like, how do we break that? Or what would you say in that situation when someone's trying to push you away?
So one of the funny things is I always tell people, I don't know if it's better to say I'm a psychiatrist when I walk in the room or a palliative care doctor. Right? Like neither one people are really excited to see. Like,
yeah, the Grim Reaper is coming.
Right. I mean, that's what unfortunately a lot of America thinks palliative care is. It's the H word, right? It's just the hospice undercover. But I find that my position, I think it's this really interesting combination between psychiatry and palliative care and this hybrid that's happened in me. That I always try to come from the most compassionate point for people. So I saw someone today, and he's a older guy, and he's got multiple medical problems, came in for a lap choline. He's now been in the hospital for 6 weeks, totally deconditioned. And everyone said he's really grumpy, he's really mean. My nurse practitioner went to see him, and he wouldn't talk to her. And so like I went in there and kind of sat down on the bed, and I said to him, so this whole thing really sucks, doesn't it? And he looked at me. I said, it's kind of like Gilligan's Island. Like you thought you were like coming on like a 2-day tour. You've been here forever. And he kind of looked at me and started smiling. And then I cursed a little bit and he cursed a little bit. And then we got into this conversation. So I think it's all about how you frame it. I mean, if you come in and try to identify with the patient's experience, and I think that's the more important part, not necessarily the title you're wearing. Because I think people have biases, but if you come in and kind of break that really quickly, then it's really hard for them to hold that bias with you.
Wow. I love that. I love that. So I'm going to extrapolate a little bit for the students listening in, doctors, of course. And especially for me too, I've been on medicine now for quite a while. To be honest, I haven't been on a psych rotation as a resident yet, which is hilarious. Just because of the way things are scheduled. But I will say, you know, you get so stuck in, you know, oh, I have to manage these medications. Oh, the nurses need to know about X, Y, and Z. Oh, I need to call this consultant. You know, you get so stuck in your head, you forget when you walk in the room that, wait a second, I need to give this patient a good experience in some fashion and let them know I'm there for them. So for everyone listening in, how do we manage? The question I ask, and maybe to reflect on, is how do we manage those times when we're super busy, but then we have to go into that room and, you know, empathize and be there for the patient, you know, realize the experience they're having, and how do we kind of take that into account, even if we're in a rush? And obviously, you know, there's methods to do that, but, you know, just how do we do a better job there? I mean, that's a big question. It's, you know, obviously a difficult answer. I think it's scenario based, right? But
sure. I mean, the data is really interesting. So the data shows if a physician sits down in the room, patients on average think they spend 5 to 10 minutes longer versus the doctor standing there.
Wow.
I mean, so like just the idea of you sitting down changes the frame of how long a patient thinks they're there for.
That's awesome.
Which is a really odd thing, because inherently in all the pictures you see from the early 1800s, doctors are always sitting. But if you go into any hospital, doctors are always standing.
Yeah.
And the Eastern culture, I always think it's fascinating, because the hierarchy of where you're sitting, the highest seat is the highest person in the room. And it goes down. And I think just getting on people's eye level. But for me, I think that's one of the ways I check myself.
I love that tip. I love it.
If you have to sit down, then you're going to be there. And even you physically, the patient's going to think you're longer there, but more so you have to be there because you're kind of just putting yourself down. I'm known, my staff laughs because there's these trash cans because there's never seats in the rooms, which is the other thing that's up. So I always have these trash cans. I'll pull over and I sit down on the top of the trash can.
Wow.
I'm kind of tall. My feet are kind of dangling, which I think is kind of this like very playful thing for patients to see a doctor do that. And that's my other goal with patients, is just make them laugh. I mean, if you can make a patient laugh, then the whole visit was worth it.
That's awesome. I love that. That's great. Great tips there. So I think this would be a good point for us to kind of talk about not necessarily the whole like psych residency experience, but what made you decide, number one, to go into palliative care? For those who might be interested. Before we dig into that, though, I think people have a misconception about what palliative care is. Can you kind of just like give like a brief overview? So, because I didn't even really know what it was that well until I did a week of it. So,
sure. So, historically, there's been hospice, and that's what everyone thinks of. Hospice is defined by 6 months to death. So, anyone that supposedly has a 6 months or less prognosis can enter into hospice. Thankfully, we've gotten so much more advanced in medicine that people live much longer than 6 months, and we have a really hard time telling who's going to have 6 months. So before, even with lung cancer, things are changing so quickly right now that people are living much longer. But at the same time, they sometimes need care that's going to be congruent with what they need, that might be, quote, more comfort focused. So we extend out much longer than the 6 months. We also are kind of an add-on. We came out of oncology, and so our focus is symptom management. So things like pain, nausea, diarrhea, constipation, all shortness of breath, all the things that make being in the hospital miserable for patients. We're actually are trained specifically in symptom management. And then the other thing that we do is a lot of engagement with all the medical providers. Our healthcare system works in silos. And a lot of my patients are so complicated. They have heart problems, they have kidney problems, they have lung problems, and I always tell people it's like 5 blind men around the elephant. The guy at the ears telling you it's like a pancake, the guy at the legs telling you it's round. But the problem is no one's connecting that it's an elephant. And so I think my job is, sometimes I tell patients, is tell the 5 blind men it's an elephant, and this is where the elephant's located. And so sometimes people get that, sometimes they don't. But like the concept, I think, is good. So palliative care, we're really just an add-on. And we help with families. We also have this wonderful ability to getting to know people and getting to know what they need and what they want. So some of my patients don't want chemotherapy because they want to go home and spend their last days at home. And if they got that chemotherapy, they're going to be really sick and end up in a skilled nursing facility. Mm-hmm. So our team is the team that talks to them on the front side of being, this is the risk, this is the benefit. Where do you want to be? And then we can help you get there.
Yeah. So great explanation. And I think the one way someone explained it to me, like super simply, was I think a lot of times doctors do all the stuff you really don't want them to do. They put tubes down you, they put tubes up your butt, they're always messing with you, listening to you, waking up at random times, whatever. And then the palliative care doctors, the one time where like you just give them exactly what they want.
Your answer is better. I'm going to steal that now.
I'm just paraphrasing what you're saying.
No, I like yours though, but it's much cleaner. I think it's cleaner. But yeah, that's exactly right.
And then, so I love that. And then I also didn't realize with palliative care, and this is something you wouldn't realize unless you're on the inside, which is like a lot of doctors do tiptoe around the idea that like what is going on with the patient is probably going to lead to death at some point. So they say, well, we're not exactly sure what the course of this disease is going to be. Like you never want to be the definitive person. And I think, when I worked on palliative care, like this was the time where when I was working with the doctors, like this is a terminal disease. You will die from this. Very definitive word choices, which is a very different thing. I think that's you can comment on this. Like, I'm sure that's really tough, but also in some ways maybe reassuring. I mean, I'm sure it can go a couple ways, but yeah, what is that experience like being the kind of more definitive individual in the process?
It's interesting. In palliative care fellowship, one of the things we learn is to be definitive. And it's really interesting process. As a psychiatrist, mine was a little bit different because of doing psychotherapy and things like that. But a lot of my colleagues in internal medicine, it's really hard to give someone bad news and not do something like, we can't give you any chemotherapy, but maybe we could do radiation, right? Like that but is so hard. And I think it's partially because we're trained from medical school on cure, cure, cure. And so it's a really difficult thing to get practice with, but it's kind of practicing breaking bad news. And I always like to say, there's always something we can do. I mean, back in the early, let's say 1900s, before antibiotics, most doctors just sat at the bedside when people were septic. We didn't have antibiotics. They just knew to sit there and be with the family. And in some ways it's kind of vintage doctoring. Mm-hmm. You're going back and just being with patients, but it's difficult. And I think, I don't fault any physicians for having trouble with it because I think I had to do special training for it. And I also think there's pressures of the medical system. Like I would much rather have my surgeons in the OR doing more surgeries, saving more lives than spending an hour having these conversations, which they might not enjoy and they might not necessarily have the ability to do.
Their skill set. Yeah. Like they're not trained to have that. Yeah.
Right. So I think it's a skill set. It's an orientation, but it takes time. And even when I have residents and medical students sometimes with me, it's a really hard thing to do. And we'll prep before and they're going to do it. And then they get in there and it's so hard for them. We call it dropping the hammer because it's really just that final nail and it's really hard to do.
Yeah. Yeah, it's tough. When I was, on palliative care for that week, I told you this earlier in our previous conversation, but we were caught up in a lot of stuff, and my attending at the time was like, Taylor, you can go in and start to have the conversation with the family. And I was so lost in like thinking about like the previous patients we saw, and all of a sudden I'm walking in. I don't think I really fully prepped myself, and I go in. And then all of a sudden I realized I'm like, I'm going to say it straight. I was like, holy shit. This is what I was saying in my head. Holy shit. Mm-hmm. I'm about to tell these family members that did not know that this patient is about to die, like definitively from this lung cancer. I had this moment. I was like, crap, I'm about to say this. And then I said it and I was like, that just happened. And then I saw the result of that. And I'm like, that just happened. The family's crying. And it was like such a weird experience. So yeah, I like totally can tell you it's extremely hard. And you, as a human being, you feel for everyone in that room because this is the news that you would never want to hear yourself. And so it's a very tough experience. So I'm sure the techniques and all that stuff, we can talk about that, but right. We don't need to talk about that per se, but what is it like, how is that for you to decide, that's going to be a specialty I'm going to go into where I'm dropping the hammer on a lot of family. Like, what was that for you? Why did you want to go into that?
Sure. So during my third year of medical school, my uncle got diagnosed with pancreatic cancer, went around the country because he's in his 40s and ended up dying in the OR. My grandmother, his mother at the time, actually got diagnosed with lung cancer, with brain mets. And she did one chemotherapy and made a decision that she just wanted to have a bucket list, which included getting a tattoo on her arm of her dog's name, which was hilarious. None of her children or grandchildren, but the dog's name on her arm. And she had all these things. She built this beautiful garden. And so like as a third year, like I saw these two very different ways approaching death. And I think for me, studying Tibetan Buddhism, the whole practice, I think, of the religion is to prepare for death, to try to increase your reincarnation. So I had been studying about it in this kind of unique way through religion. And it allowed me to kind of come and circle back. I always think of, there's a famous child psychiatrist named Winnicott, who is a pediatrician. He talked about transitional objects, which everyone probably knows, like stuffed animal. And he also talked about transitional space and a holding environment. And it's kind of like when your baby's upset, you're kind of holding them. And I find that when you're in these conversations with families and patients, it's like this sacred space that you enter. And it's a space no one wants to enter, but ironically, all of us at some point will have this conversation. We'll all have to enter it. And so a lot of times it's this position where I go in and I try to figure out what their prognostic awareness is, which is a fancy term of how far do they know we are. And then from there, kind of move with them to that place. It's amazing too how many times patients know. There's been many times where I've just gone in and sat down on a bedside with a family and just held a patient's hand and just they start crying. Wow. And like and it's not anything I had to say. I mean, I think we were just all there. Sometimes it's the exact opposite and people are kicking and screaming and yelling. And I think each experience is different. But as I shared with you before, it's also this amazing space to be in as a psychiatrist, because as psychiatrists, we're always trying to get people to take better care of themselves and improve their relationships and do all these things. But when you have death, like literally knocking on your door, people make these incredible things. Like I've seen people call their siblings who they haven't talked in 30 years to say like, hey, I love you, or to call that son and say, hey, like, I apologize for not being a good dad. Like these really powerful human emotions. So sometimes I don't know if I'm just an endorphin junkie for emotions, because it's high emotions that you see all day long. And so your question was, how do I do it? I think it's the same way you talked about doing this podcast. Like it's more work and time that you're doing in your schedule, but it also recharges you. And there is a part of this that definitely is recharging, but you also have to be a bit careful with it too, because I think it's getting too close to the flame, it would burn you out at the same time.
Yeah, there's a balance there for sure. And I think there was something that we talked about before in terms of, and you kind of alluded to it, that bucket list, for example, the things you always wanted to do. And all of a sudden, when you realize that your time is very short or limited, it really forces you to kind of deal with those things you never said. Yep. Or the things that you never did or have done. And we had brought up before, Steve Jobs, he has that famous quote in one of his speeches. I forgot where he spoke. He said it at, was that Stanford? Anyways, and he talked about basically the fact that when you realize that today might be your last day, the thing that drove him was knowing that this day might be his last day and he wanted to live it out completely. Hashtag YOLO, like everyone's saying, but not in that way, but in like, in the way that, it's time to do what you've really wanted to do, and having these like really sensitive, powerful conversations you're talking about with family members, telling them I love them. It's pretty nuts. But thank you for sharing that. That's a really great perspective. Didn't think about it like that. So moving on, now we get even more into it. We talk about, you went into obviously adult palliative care, but sure, you're very unique. I mean, I've heard of palliative care, but I've never spoken to someone that's done child palliative care.
Sure.
What is, how did you find out? How did you build that into your career? What was that experience like?
So during my third year, as we mentioned before, after my grandmother and uncle died, I was on my pediatric rotation, and there was this little girl who had methylmalonic acidemia, which is a fancy word for her pH in her blood was off. And she'd been in the hospital for she was about 5 years old, and she'd been in the hospital for majority of her life. And I was kind of assigned to her as a pediatric rotation. And it was this thing where I started looking more and more into what was going on with her. And as someone that thought they would go into child psychiatry, she was developmentally delayed. I saw a lot of attachment issues. There were a lot of things that was concerning to me. And so I was telling my father about it, and he said, well, I know this guy who does this thing with kids. I don't know. I think it's Pediatric Palliative Care. Why don't you check him out? And so I spent time with them. It's called an organization called Noah's Children. And Dr. Archuleta was one of the first pediatricians entering into the pediatric palliative care space. And I went on a couple of home visits with them, and I was totally hooked by spending time with people in homes, being with families, being with kids. It became really clear to me that there needed to be more psychiatry influence into this field, and also how much the families need help.
Okay. Wow. And do you find it, more difficult because this is with children and they've had, they have so much life to live, and all of a sudden that's kind of getting cut off, and you're seeing, the issues that come up with disease and everything. Do you feel like that makes the process more difficult? Has the experience changed rather than what you see with adults?
Well, I think it's unique. I mean, so there's two divisions, I think, in pediatric palliative care. There's a lot of the kids that are born with the things they tell you in medical school people don't survive. So trisomy 13 or trisomy 18. I've seen that a lot of those kids, or children with different types of birth defects. And so in some ways, those families always feel like it's a blessing that their kids have even been born. And a lot of those kids have lived longer than their prognosis. Mm-hmm. But because of the neurological consequences with those children, sometimes I don't necessarily have as strong a connection with the child as the parents. And so you end up spending a lot of time with the parents. So that's unique. But in adult palliative care, you're also kind of sometimes working with parents or children of parents. I mean, that relationship's a little bit different. I think the harder part of it is being with kids with cancer that are older, and they've lived their lives and things have been, quote, normal, and then suddenly things took this terrible turn. But within that, it's always amazing how kids are kids. I remember this little boy who had pretty bad cancer, and I did a home visit, and all he wanted to do was play his Xbox. He really didn't want to talk to me about anything. And so I played Xbox with him. And we talked about a girl that he had a crush on. It was a totally normal thing that I'd be talking to any other 14-year-old patient that would have come into my psychiatry office. So I think kids also have this ability to just be kids and be really, really mindful and present. So it's a gift in the sense that I get to spend time with them and just see how they live their lives, and again, not take anything for granted.
Wow. That's awesome. And you were saying something there are a couple things that you said that were very powerful to me. Number one, I think it's so crazy. These kids, the Xbox scenario, this child knows he's sick, right? There's no question about it. He's aware, and he's talking about this crush he has and playing his Xbox. I think it's just so cool that he's just able to be him, in that situation. That's really cool. And the other thing I'm thinking about is from your perspective, I'm sure being in these situations probably changes you in some way too. You're seeing these experiences. How do you think that, dealing with death on a consistent basis, how do you think that affects the way you live your life?
Sure. That's a great question. So first, I think there's always a risk of burnout. So I think one of the things that I've realized is you've got to put things in place to make sure you don't burn out, because I think death and dying is just extremely intense. And I think my belief is everyone has a rate limiting step with it. And once you hit that, you just can't do anymore. So I definitely am really conscious of working out and spending time and not always being in this world of death and dying. But I do think it changes the way I view life. Specifically, they say that there's I guess a famous quote that light's always brightest in the darkest of moments. And so I actually have more memories of being with these families laughing or doing something really fun than I have of like the agony of the death and dying. And so in some ways, everything's a little bittersweet. Like if you know it's your last time to go home, or it's your last milkshake, or your last whatever, anything that's last, you savor it in a different way. I think it's a description I told someone. It's like when you're backpacking for a week and you haven't showered and you've been like out in the wilderness in a tent, and like you get home and you smell and you feel disgusting, and you get into that shower and you're just like, oh, this feels so good. And there's like no words for it, but like, oh, this is great.
Yeah.
I think it makes all your life experiences a little bit sweeter like that. And listen, I get upset and I get frustrated. That's just the reality of it. But I do think sometimes I'll be spending time with my nephew or my mom or my father or my sister or someone, and like I pause and just like, oh, this is a great moment. Like I want to just like savor this moment. I also have the other thing that I think has changed remarkably in me is that when I say goodbye, I'm much more conscious of saying goodbye. Because there's been so many times I was not conscious of saying goodbye to patients and then they died.
Wow.
And that's a really weird thing.
Yeah.
So that when I say goodbye, like I'm much more conscious of like saying goodbye and making sure I say what I want to say.
Mm-hmm.
Because you might not have another chance.
Yeah.
But it's the down part of this is so funny. Not like a haha way, but whenever I talk about this stuff, like everyone's voices get like a little bit more quiet and people slow down. And that's just part of what all of us do in this thing. But I think there is still a lot of, makes things more joyful. But death and dying can be really depressing. Like really depressing if you sit in it all the time.
Sure. So, you talked about it can be depressing, and I guess a good spin-off from here is, you talked about working out, you talked about, kind of getting away from it. What are some protective mechanisms that you use to stop yourself from getting burnt out?
So I think finding humor and stuff. Like I'm constantly trying to make my team laugh. We're always doing something silly or goofy. If that's dressing up with like wigs during rounds, or to like making bets on ridiculous things. I mean, I think the major thing is always to try to keep laughing. I always say I'd rather be laughing than crying. I think that's really important. I think also the fact of making sure you have a really good support system. And for me, that includes having a psychotherapist, a therapist that I'm talking to. And I've been in therapy for a long, long time. And I think as a psychiatrist, that's not as weird necessarily, but I think, like my staff, I push pretty hard to be in their own therapy because it's going to stir stuff up in you. And I think therapy is kind of like going to the gym for your brain. Sleeping, eating, just keeping the basic things that I probably should be telling you, Taylor, right now to make sure you're doing while you're on rotation. Because once you start losing that stuff, things can get weird quickly.
Yeah. And I'll tell you, like, for those listening that are in training or going to go into residency and those things, like, it's hard. I mean, I'm a pretty happy-go-lucky guy. I'm pretty light and easy, and I'm goofy and all that stuff. But when you lose consistent amounts of sleep, it's pretty tough to be cheerful. I mean, when you're just, I've had situations where, like, honestly, I was thinking in my head, I shouldn't be here right now. This, the way I'm thinking, the way I'm not retaining information right now. But on the flip side, we spoke about this actually in a different podcast. The medical system is very strapped for resources, including manpower. And when you're on a medicine team, for example, and you are important, like if you don't show up, it puts a burden on everyone else. I know you know how that feels like. Even if you're not feeling well, you still push yourself. And that's a tough situation. I said before this conversation, I'm definitely in a little bit of sleep deprived mode right now. But that just makes it all the more important to really check in, sleep and do all the things that are really important. And so I do want to focus in a little bit on your practice. So you run this program, right? The Center for Palliative Care, Palliative Psychiatry, correct?
Sure.
And you said you make it light and all those things. So what are some of the things that you implement that you think make it, you said like wigs, like, so what are some of the creative things you do to like lighten up the mood?
Sure. So, on the palliative care team at the hospital, when you walk into our office, we have this kind of like a little bit like a hallway. And so when I was growing up, I used to like those glow in the dark stars that you put on the ceilings, like those really cheesy ones. Yeah. So
I know exactly what you're talking about. Yeah.
So, when someone dies, or we find out someone dies, we usually put a star up for them on the wall.
Wow.
And have a black light. So it's like this kind of playful thing. It's kind of a memorial thing, but also is not super serious. Wow. On some level. So we have that. Recently, my staff, one of my social worker on the team has been pregnant, so she really wanted an exercise ball seat. You know, we all have exercise balls that we sub out for chairs, which like I'm constantly trying to like be a little kid and try to bump into other people, but no one else seems to really enjoy doing that as much as I do. For a while, we actually had a therapy dog on our team.
Wow.
The dog itself himself had cancer. So we were actually like palliating the dog who was on our team for a while, which was like really interesting because when the dog died, the poor owner, I had spent a lot of time doing bereavement counseling. And there's other things that we just joke about. I mean, I think part of the thing is talking about movies, talking about books, talking about people's names,
talking about life besides just the work. And I can tell you, you know, when you start, you know, seeing the same, this is my life right now for people listening, like my life. And you know this, like you work 12, 13 hours, you go home, you do like something super small, like sit on the couch, watch a movie. Maybe you try to get a workout in, make some food, whatever. And then like literally maybe you have 2-3 hours at home, you go to sleep, you wake up and you're with the same people. It's like, oh, I just saw you. Like you literally spend more time with your coworkers than you do with, you know, your loved ones, your family members, like, and
you know things about them that you never thought, you never wanted to know, but you know about them, right? Like just really weird stuff about what they do in life because you're spending so much time with them.
And and it's just this random group of people that happen to be, you know, in the hospital. And it's not just the doctors too. It's the janitors, it's the nurses. Some of the nurses love you, some of the nurses hate you. You have no idea why. It's the weirdest thing. And I just love talking about, you know, how do you make it light? Because I think if you get caught up in the monotony of a lot of it will just make you go crazy sometimes. But I think if you just constantly, and we talk about this on podcasts, like how do we make this monotonous part of the work more human? Because we're all trying to do that.
I'll tell you this funny story. I might get in trouble because this is being recorded, but one of my friends on our internal medicine rotation, we were family medicine at this really small hospital in Rhode Island. And so he and I had opposite call nights and we were Q3 and we'd be up for like close to like, I don't know, 35 hours or something ridiculous because it was for the work hour rules. And so the game we would play is we would get signed out about 40 patients to cover at night. We were supposed to be responsible.
That's a lot. Wow.
And so the game was you put a fake patient on the list. And in the morning, when you signed back into the other person, you had to say who you thought the fake patient was. Because as you know, you're not going to get called on 40 patients.
Right.
But you would try to put something in there to make it like either like a little bit ridiculous, either the name or the symptom or the chief complaint.
But believable enough.
Believable enough, but you had to leave some type of token so that you knew it was not. And so that was like how we made it funny. And like, it was like this really ridiculous game. Our senior like hated it, but I think at some point she knew we were so burnt out that was the only way we keep going.
Yeah.
So I think I'm always have had this ability to find some games or something fun. Because as you said, it'll just burn you out unless you start. And I think also doing certain things in your schedule that you enjoy. So when I was in internal medicine intern, we could sneak out on the rooftop, and there was the Red Sox minor league, the Paw Sox. You could see their stadium. So we would always sneak out there and try to like watch the lights or fireworks or whatever was going on. And that was something that a tradition we would always do on Fridays. So I think traditions, we know culturally, mark time. And so I think traditions are really important. I mean, that glow in the dark stars, it's a tradition on my team now. And I think those traditions are really, really, really helpful.
Sure. So, what I'm hearing here is, something even, residents or seniors, attendings can maybe apply to make things a little lighter is what are some, I love that. I love the secret patient idea. That's so funny. So what are some things that obviously still maintaining some sense of professionality, not hurting anyone, but what are things you can do on your teams that adds in a little bit of tradition, adds in a little bit of fun, so that we can make, the process a little bit lighter, even in the difficulties that we have? I think that's a great question. And everyone could do that differently. Maybe people could, comment on this on our social media channels or something. Send a tweet to Dr. David Buxton. It's David Buxton, MD, right?
You got
That's it. That's a Twitter handle.
Yeah. So, the other funny thing we used to do, one of my attendings is, anyone that knows the old movie, like, I don't know if it's old, but Mean Girls, there's this line where she says, on Wednesdays we wear pink. And so every Wednesday we'd all dress in pink. And people would really take it to the next level, wearing sweatbands and really owning it. So I think that's the same idea. So I had to share that too.
No, I love that because, it really emphasizes, I think, again, people get caught up in the monotony of it and doctors being so professional. But I think, when you can be able to be a little goofy, be a little human, it really takes out the stress of, having to hold this high regard or higher sense of hierarchy in those things. So that's really cool. So questions that I like to ask all of my guests, and, this being the Happy Doc, I like to really emphasize this. So who inspires you and why?
I would say my father. He's been an amazing physician. I think he's also been an amazing father. But what's been inspiring to me is that he was in psychiatry at this time where they really didn't have many medications. And he was able to kind of stay with the wave of all the different medications coming out, but also at the end of the day, still loves seeing patients. Even as in his retirement, which he just did a couple months ago, he still sees some patients and still does that. And I think what Happy Doctor is about, I think find the pure parts of medicine that you really enjoy. And I think he hones that. The other person that I really admire is actually one of my closest mentors is a geriatric psychiatrist, which is kind of an ironic thing, being a child psychiatrist. But he has this amazing ability to meet patients that are having dementia and figuring out ways to have them be in a better space. So a little story of that, which I love telling, is that we had this patient who had been kicked out of 3 or 4 nursing homes and was really an aggressive guy. And he was this Italian guy. And we kept putting medications on. There were all these complications. And so my mentor, Dr. Marino, and I, he turned to me and said, we're going to take a field trip. And we're in Rhode Island. So we go to the kind of Italian district of Rhode Island. And we get lunch. And I have no idea why we're doing this. And then we go to this this grocery store and gets all this Italian sausage. And we get back on the unit, and I don't know why we're doing this. And he's telling the nursing staff, I got this. So he starts cutting it up, and I'm like, this is so weird. Why did we go for lunch? I'm an intern here. Why are we going to this area? Why did we get sausages? And so this gentleman starts yelling, and he says, Mr. So-and-so, come over. And the guy walks over, and he gives him a piece of Italian sausage, and the guy calms down and starts talking about how good the sausage was. And so literally this gentleman's treatment plan was, when upset, give him Italian sausage. And he actually did amazingly well, right? He did great. He ended up never coming back to the unit. His family was happy. They loved making food. He was happy. Everyone won. And so Dr. Marino is this, and I actually, ironically, once a year I take a 1 week sabbatical, even as an attending now, and I've been at training for 5 years. I go spend a week with him, and I still learn from him because he has this brilliant way of thinking outside of the box. That's just a fantastic thing, and I always try to say to myself, like, how can I think out of the box? How can I get into what this patient needs?
So just to add on that, I mean, what field of medicine would it be okay to buy a bunch of sausage and say, this is okay, like, this is for you?
And I don't know if that was okay by how.
I don't know if it's okay either, but I just
shorten the length of stay, so I think people are happy that nothing else was working.
I think they need to do a randomized, controlled, double-blinded study on the effects of sausage in the hospital.
On agitation.
Oh my gosh!
The key that everyone had missed, but Dr. Marino hadn't, was he actually was an Italian chef for years when he was younger. So that was the brilliant part. He's like a Sherlock Holmes, right? Like, everyone else missed that detail.
Yeah.
But he had picked up that detail when he was taking the history.
That's so funny. So he was able to kind of, take, that story and help him out in a different way. That's really cool. I love that. What do you think is something you wish you would have heard sooner in your medical training, or something you would have told a younger self to improve your experience as a student or as a doctor?
I wish I knew that we put so much effort into the step 1, step 2, which are national exams. And I wish I had known to myself that everything was going to be okay. Just learn what you can learn from everyone and not worry about studying for the exam and studying for the score, but actually learning what you're supposed to learn. Because I think in medical school, there's just this current of like grades because pre-med and medical school. And I think, once you really get into that groove, you lose the fact that learning is really what being a doctor is about. Like, you can only be as good of a doctor as good of a learner you are. If you're not continually learning as a doctor, you're going to fall behind and not be a good doctor. So, like, I think in some ways getting that fundamental way of learning and knowing how you learn is actually more important now, because the reality of it is we have Wikipedia or Dr. Wikipedia or Dr. Google or like, so like what we used to have to remember, yes, we need to know it, but we also need to be able to like remember what we need to know and then look it up. And so in some ways, I think if we could get back to learning, it would make the whole process much better. But I lost that. I definitely lost that in medical school for a while.
Yeah. I mean, and we talk about competition and, the culture of medicine and how that might not be the best way to look at things. And how that affects our learning process, in other podcast episodes. That's like a whole, it's a whole thing in and of itself. So it's an interesting topic for sure. What is, I mean, I think we talked about this too. This is, your work recharges you. I was going to say what recharges you, but I think, your work is a double-edged sword in that, it recharges you, but you also have to be careful. You're saying you're playing with fire a little bit.
Sure. And I love ideas, right? Like, so that's what charges me, like meeting you and hearing some of your ideas. I mean, I think I get recharged by hearing people's ideas. I think I also would tell people, like, do things that are totally out of your medical space. So when I was a resident at Harvard, I had a friend that was involved with the Boston Ballet. And so like I got really active in the Boston Ballet and going to performances because it's so different from how we normally think. Mm-hmm. And so like I would say like part of the thing that recharging is going to do things that you're totally out of your comfort zone, you know nothing about. And because I think it actually makes you a better physician because you're taking away things and makes you look at problems really differently.
I love that. That's awesome. So what is one tip that you would like to leave to listeners today? And if you don't have one, by the way, I have a theme that I've gotten out of this conversation, but you can.
Okay. I'll try. My tip would be is if you're starting off in the process of being a doctor, write down why you want to be a doctor. And then check in with that every time you go to the next stage. because you get lost. You can get really lost, as we like to say on the team. Sometimes you get all you see are trees and you forget you're in a forest. Mm-hmm. And I think the medical school process, the residency process, the training process of intern residency, it can really wear you down this way. And sometimes you get lost, but most people end up in medicine is because they really want to take care of, help people. If you wanted to make money, you went to the wrong specialty. You should become an investment banker, right?
Yeah.
Like if you want to argue, you might be a better lawyer, but most people are ending up in medicine because they really enjoy taking care of people. But sometimes I think that gets beaten out of people. So I think remember that reason and hold that reason really close to your heart.
I love it.
I didn't mean to make that sad. It came out sad.
No, that didn't come out sad. That like when I heard that, I was like, put that on a billboard. Like, take this recording and put it in a freaking like megaphone. That was what I got out of that personally. So
okay, good. Well, then at least someone I'm feeling better about now.
I'll tell you right now, if no one else is listening to this but me, that's fine.
Good. Mission accomplished. Mission accomplished then.
No, seriously, it's great. Guys, I only do this podcast for self-gratification. This is sarcasm. Yeah, so that's great. I love that. Great tip. And the overall theme I got from, this conversation, something I'm taking away, is you take very difficult, and this is a theme I'm getting from you, just getting to know you a little bit, is you take very difficult situations such as death and dying, whether it's with adults or kids, and your mindset is you don't hold on to the negative aspects. You obviously remember them, but you really do look at the positive stuff, and you remember those things, and you also have this ability to take those difficult situations and not poke fun at it, but you're able to make things lighter. Whether it's in your workspace, you're talking about the wigs or the patient, like the secret patient. I love that. You take this very rigid and, often like tough and hard situation, and you just lighten it up. And there's a very subtle finesse in that. There's a very subtle thing that you're doing that I think is a really great takeaway. So even though people might feel trapped a lot of times in the work that they do, they don't look at the forest, they're stuck in the trees. I think the main theme is there's ways to lighten up difficult situations until you kind of get where you want to go. And so I think that's a big takeaway from this conversation. And I appreciate your time here today. I learned personally a lot through that. Learned a lot about the process of palliative care and child palliative care. I want everyone listening today to check out Dr. David Buxton. Is it David Buxton MD at Twitter? It's on Twitter, right? David.
Yeah, that's right.
At David Buxton MD for Twitter. The website is, and you tell me the website very quickly.
Sure. Yeah, it's www.davidbuxtonmd.com. So same thing, all lines up together.
Beautiful. www.davidbuxtonmd.com to connect. You can also tweet at the Happy Doc 1 just to ask a question, say that you love the conversation. You can find us on iTunes. You guys know that. And as a follow-up, we have this connection here. If you guys have any questions, it'll be great to follow up and answer anything that you guys have. That was an awesome conversation. Thank you so much for being on today.
Thank you so much. It's been a pleasure.
Hey guys, we hope you enjoyed this episode, and we want you to definitely subscribe to our social media channels. Check out the Happy Doc on Facebook, iTunes, Twitter, and Instagram. Please like, subscribe, share, and send us feedback. And please check out the website, www.thehappydoc.com. Again, we hope you enjoyed The Happy Doc, the voice of fulfilled physicians. Peace out.